YouTube check ചെയ്തോളൂ കേട്ടോ.
Start, sir. Live start, sir.
Are we on live?
Yes, sir.
Okay, I can start the class, right? Good evening, friends. I hope all of you are ready, and we will just go through a very short session which is filled with previously asked questions. And this is going to be interesting in the way that it is entirely made up of questions which have been asked previously, or there is a high tendency to ask in any of the competitive exams. And most of them are very, very pertinent to the current scenario. And please go through that. We will do it very fast and concise so that we will not waste time on that. Okay. Most of them are pictures. We have around 25 to 26 pictures, which has been of very use for you in your practice. Okay. So have a look. We will see one by one. Now, I know most of you would have seen this figure when you start studying about anesthesia. And the most important point in this is that this is something which tells you that whether you are going to deal with a difficult intubation or is it going to be an easy intubation. This is discovered by a person called Maly. As you all know, Maly is a person. Maly is a person. He is basically from Andhra, India, and world over, this is considered to be a gold standard in assessment of the airway. Now, even after so long, after the discovery, although it has been modified by Samsung and Young, it is still important and used. Now, the question when they ask, we have to keep in mind few important points. Now, first one, it is for assessing the airway. As we already know, it is to assess the airway. Okay. Now, the second point what you have to know is the patient is mostly sitting. You should not assess this in a lying down patient, sitting patient. Third important point what you need to remember in this case is that the tongue should be protruded. Tongue should be out. Okay, tongue should be kept out. It is, as you can see from the figure, and the person should not phonate. No phonation. We should not say ah. That kind of phonation should not be there. It is simple. Sit, open the mouth. They found out the relative space between the oral cavity and the tongue. In fact, if you have a large tongue in comparison with the oral cavity, you have small space for the endotracheal tube to pass. That's a simple logic. Okay. So as you can see, the first one, 1 and 2 is considered to be very easy. 3 and 4 is supposed to be a difficult intubation. So that is Maly assessment. Now, if they will give you a figure and ask you to identify which Maly class does it belong to. Although you'll have to see the anterior pillar, the posterior pillar, the soft palate, the hard palate, the relative tongue, surface of the tongue, etc. The easiest thing to identify is look to the uvula. Now, as you can see in this figure, please see the uvula. Uvula is completely visible in 1, while the tip of uvula is lost in 2. And only the base is seen in 3, and there is no uvula visible in 4. That is probably the easiest way to identify Maly. Okay, so remember this. This is very important. Now, if I have to talk about doing an airway assessment in the pre-anesthetic checkup room, Maly is okay. But there are situations where you cannot come back. Like you paralyze the patient after induction and then do the laryngoscopy and then find out, oh, I cannot intubate this, or, oh, it is very easy to intubate. So assessment of an airway after doing a laryngoscopy is done by Cormac and Lehane classification. So this is the second assessment tool which we use very commonly, especially to communicate between laryngoscopist or the anesthesiologist, how easy or how difficult the intubation is. This is called Cormac and Lehane classification. Okay, Cormac and Lehane classification. This is also important and has been asked many times. So remember this. This is Cormac and Lehane. And Lehane classification. Okay, remember this. Now this figure is simple. You can see a laryngoscope blade has been put and it has been lifted so that you see the entire vocal cord here. I'll get it into another color so that it is easily visible. See, this is your epiglottis on top, and you can see the entire vocal cord. The full glottic opening is visible. This is considered to be easy intubation and Cormac and Lehane 1. Now, once you see only the portion of it or half of it, you can only see half of it, it becomes 2. Because the epiglottis, this one is epiglottis, it is hanging over into the glottic opening. Now see, nothing is visible. You can only see the epiglottis even after doing the laryngoscopy. It becomes 3. And it becomes 3. And even the epiglottis is also not seen, which is considered to be a difficult thing. Then it's called 4. So as you know, 1 and 2 is easy. 3 and 4 is difficult. Again, 3 is considered as 3A and B, depending upon the visibility. But for your understanding, 1 and 2 is easy intubation, 3 and 4 is difficult intubation. The point here to remember is this is not in the pre-anesthetic checkup room. This happens only when you induce the patient, paralyze the patient, do a laryngoscopy, and then visualize the vocal cord. So this is Cormac and Lehane classification. So these are the 2 points which you need to remember about laryngoscopy and airway assessment. Okay. Now, let us see another point, which is very commonly again asked, is a cannula. This has been asked many times in INICET, NEET exams. So there are many questions which come across, but see, the most important point you need to remember is the color. Color of the cannula has been asked and their associated number. For example, when it is orange, it is 14. When it is gray, it is 16. Green, it is 18. 20, it is pink. 22, it is blue. 24, it is yellow. So this is important. Now, great, green, parks, beautiful, yellow, valley. This is probably one code which I always tell my friends to remember the cannula size. O is orange, which starts with 14. Great is green, gray is 16 gauge. Then green comes 18 gauge. Pink comes 20 gauge. Then blue comes 22. Yellow become 24. And violet become 26. Okay. So this is one code which you can be of use to remember the color coding of the cannula. Now, there are a few points which also you should keep in mind, especially is which are the large bore cannulas, large bore cannulas, which has got larger space for the fluid to go. For example, 14, 16, 18. You can generally consider this as a large bore cannula because this is important whenever you want to do a volume resuscitation, okay, volume resuscitation as in a patient with shock, or this is also important when you want to treat a patient in hypotension, and this is also important whenever you give regional technique, regional anesthesia, especially subarachnoid block or spinal, where the commonest side effect is hypotension. So you need to give large amount of fluids. This is also probably the best choice when you want to transfuse blood and blood products. Okay. So these are large bore cannulas. This has also been asked. Now, if you are thinking about general anesthesia, if you are thinking about general anesthesia, probably you can think about 20 gauge needle, which is the pink one. Okay, pink one. Now, if you again come down to smaller gauge, for example, blue, these ones, the 22, 24, and 26. These are smaller gauge cannulas, which are essentially used in pediatric population. Pediatrics. Okay. So when you have time, please do study the flow rates of few of the cannulas also, because that can also be asked as a question for you. Okay. So remember that. Now, and one more thing, before you put a cannula in pediatrics, always think about EMLA cream, EMLA, EMLA cream. Now, what is this one? This is another gadget which has been asked many times, known as the Proseal LMA. Proseal LMA. That means it is towards sealing the esophagus or sealing the defect of the original LMA, which is, it is aspiration. So when the biggest advantage of LMA is that it has been used in difficult intubation. It has been used in many situations where mass ventilation was difficult. But the disadvantage being it caused a lot of aspiration. So this aspiration can be prevented if we use this modification of LMA called Proseal LMA. Now, what is the added advantage of Proseal LMA over our classical LMA? That is naturally the question that comes to your mind. This is the tube through which air will pass, and this is the tube which is used to pass the drain tube or your Ryle's tube. Now, this Ryle's tube, which you put through this end, will come out through the tip and enter into the esophagus. And the advantage being, you can aspirate the contents of the esophagus and stomach from this tube, which come out through the tip. So, what is the advantage? It prevents aspiration. Excuse me. Now, another important point which you need to remember is the color of cylinder. Now, of which the most important one you need to remember is oxygen. Okay. Oxygen is the one which has got a, excuse me, it has got black body and white shoulder. Right now, we have a good amount of fever and sore throat running in our state. I'm also a victim for that. And I'm just recovering from that. That's what a bit of disturbance. Sorry for that. So please remember, oxygen cylinder has got a black body and a white shoulder. When it is nitrous oxide cylinder, it is completely blue. It is completely blue. Helium, we have orange. We have carbon dioxide, which is gray. And the most commonly asked cylinder color is Entenox. Entenox cylinder, which has got a blue body and blue and white shoulder, which is Entenox, which is important. Remember that. Next one, identify this. This is 2He. 2He needle. What is 2He needle used for? It is called epidural needle. Epidural needle. Now, epidural needle is identified by a white band, a dark band, and a curved tip. It has also got a stillet. The commonest mistake that you can commit is writing this as spinal needle. The commonest spinal needle, what we use is called Quincke-Babcock needle, isn't it? The Quincke-Babcock needle doesn't have a gradations and they don't have a curved tip. These are the two differences which you should know. Now, what is this one? This is a method of oxygenation, as you all know. This is called NRBM mask. Non-rebreathing mask with a reservoir. Now, it comes with two unidirectional valve. One unidirectional valve provided around 85% of FiO2. When there are two unidirectional valves, it can give up to 96% of FiO2. You need to fill the bag, pre-fill the bag before keeping it to the patient. So that is one important point which you should remember. And you need two unidirectional valve to provide almost around 96 to 100% of oxygenation, FiO2. Okay, so this has been asked also in previous exams. And what is this one? This is called HFNO. What is HFNO? High flow nasal oxygen or high flow nasal cannula. The biggest advantage of HFNO is that it can provide 100%, almost 100% FiO2 or FiO2 of 1 or 100% oxygen. Number two, apart from the other oxygenation methods, this can provide good amount of PEEP, which is not possible with other methods of oxygenation. Third, it can provide very high liters, 100 liters of oxygen, very high liters of oxygen. And humidification. Humidified oxygen can be provided. Along with that, you can also use filters. So this help to bridge the patient before he go for ventilator. It has been of immense use. It has been on immense use during COVID times. Okay. Now please see the next one. This is tracheostomy tube. What do you need to remember? It's a definitive airway. It decreases the dead space. It decreases the dead space to a significant amount. And not usually done below 6 years. Of course, you should also know you have 3 levels: upper, middle, and low tracheostomies, of which most commonly used one is middle tracheostomy, where you go at the level of isthmus. Lower one has got a higher tendency to bleed, as you all know. What is this one? This figure indicates a nasopharyngeal airway. Unlike the oropharyngeal airway, this is soft. More than that, patient tolerate this better. Tolerate it better. Another advantage is that it prevents the hypoxia that may happen due to tongue fall. As like any other airway. Now, usually made of soft rubber. Okay. Now, how is it measured? It is measured from the tip of the nose to the tragus. Tip of the nose to the tragus. Tip of nose to tragus. Some books even say that up to the external auditory meatus or even to the ankle. But the easiest way to remember is this aperture and the tragus. Okay. Now, when is it not to be put? Contraindication. That is important. Whenever there is bleeding disorders, especially there is fractures of the nasal bone, turbinale, etc. Try to avoid this. This has been asked. TUS line. What is TUS line? TUS line is important because it helps to identify the L3, L4 space. Why the space is important? This is the most common site where you do the lumbar puncture for a subarachnoid block, isn't it? So, if we draw a transverse line through the iliac crest, uppermost iliac crest, it passed through the L4 vertebra. So, one space above, when you count, it becomes the L3, L4 space where you have to give the spinal. Okay. Although this has been said that with this line you can assess the L3, L4, various studies using ultrasound and X-rays have found out that this assessment in most of the cases go wrong because of the level varies with individuals, positions, etc. But however, for exam purpose, it's better to remember TUS line. Okay. Now, another one is also what is known as Difficult Airway Society. Difficult Airway Society is a group of people, highly motivated, educated people who are dedicated their researches to manage the airway in anesthesia. So they decide various plans when you deal with a difficult airway. So sometimes they may ask you about the plans also. For example, please have a look in plan A. In plan A, it is initial intubation strategy where we use a position, a bougie, or a laryngoscope. Just change the position, put a bougie, alternate techniques like doing various kind of blades. Plan A, initial intubation. But when it becomes to plan B, you think that the conventional methods are not enough and you will have to go for what is known as supraglottic airway devices. Okay. Now, we are into a difficult stage. Then becomes plan C. C is the one which they ask very commonly question. Here, the idea is to maintain the oxygen. Intubation becomes secondary. Here, we have to maintain the oxygenation, for which you may not try intubation. You may you have to go with mask, put an airway, start ventilating, etc. Plan D is really difficult. In D, the idea is you cannot intubate, cannot ventilate. Here, you have to think about surgical cricothyrotomy and any method, front of neck access method, by which you have to go with a surgical method in order to get into the airway and oxygenate. Okay, so plan C and D is the one which you need to put your effort a bit. Okay. Now, having set up the airway, please see, this is called an airway cart, identified by various kind of laryngoscopic blade. Laryngoscope blade. Along with that, you have video laryngoscopes, etc., which has been arranged in a fashion, orderly fashion. This is called airway cart, and this has also been asked. Now, what is this one? In this, whenever you hear about something called step ladder pattern, step ladder pattern has an originally put forward by WHO in 1980s, treat cancer pains. Later, it has been explorated, the use has been explorated to treatment of non-cancer pain also. Because it brings some lot of order into the management. Like you start with a mild opioid, go with middle opioid or moderate opioids, and then strong opioids. Along with that, you add adjuvants, intervention strategies, etc. But later they modified that you don't have to necessarily climb with that. You can actually start with any ladder depending upon the severity of the pain and the patient's condition. Some patients will benefit with strong opioid, or some patients will straight away benefit with neuropathic agents or intervention, the initial go itself. So depending upon that, you can know. But WHO has provided a stepwise approach when it originally put forward. This is another block which is commonly asked, called intercostal block. Intercostal block. As you all know, intercostal space is very small, and all this, the neurovascular bundle has been thickly packed. Now, since it is thickly packed, a local anesthetic given in the vicinity of a nerve will naturally try to enter into the vessel also. And you also know that intercostal block is most of the time given in multiple sites. So what's the problem? Multiple sites, close proximity, chance for systemic spread. So systemic spread is high in intercostal block. Okay. So systemic spread is a problem. Okay. Where is it used? The indications are fracture clavicle, fracture ribs, and whenever, especially we have a flail chest, thoracic trauma, etc. These are the areas where we use intercostal block very often. Also in chronic pain therapy, whenever you want to treat an intercostal neuralgia, this is very commonly employed. Are you familiar with this diagram? This is actually a very important diagram, what is known as Sellick's maneuver. Sellick's maneuver, or this is the one which is known as rapid sequence intubation, where the drug of choice for rapid sequence induction is a fast-acting drug, thiopentone, and a fast-acting muscle relaxant, choline or rocuronium. And you apply a pressure of around 30 Newton onto cricoid cartilage, as you can see this figure. Cricoid cartilage. And why cricoid cartilage? Because this is the only complete ring. Complete ring. So remember this. And the pressure is taken out only after you put an endotracheal tube, inflate the cuff. That is also an important point which you need to remember. This is to prevent aspiration. So this is known as Sellick's maneuver. Now what is this one? This is the classic bench position or surgery in a sitting position, done mostly for a posterior fossa surgery, or this is also done in some other conditions like shoulder arthroscopy. Okay. Now, whatever be the surgery, whenever you see a patient like this, where the surgical site is above the heart position or the heart level, the first thing that should come to your mind is a risk of venous air embolism. They will give you a clinical scenario to let it be a minimal murmur, or let it be a sudden fall in EtCO2, or let it be a sudden hemodynamic compromise, fall in saturation. All this will all this they are trying to tell you that I am going to tell you about venous air embolism. Let me know whether you know this. So whenever you see sitting position, whenever you see a surgical site above the level of the heart, think about chance of venous air embolism. Okay. Now, whenever you have it, flood the area with blood or saline so that no further air is sucked in. Level that area, put the through the central line, you aspirate out the content of the air from the right atrium, and then prevent it spread into the left side of the heart. Okay. One more point, whenever you have such position where endotracheal tube can be kinked, in this case, the best is to use a flexo-metallic tube. And I'm sure most of you know flexo-metallic tube or reinforced tubes are those tubes which are kink resistant endotracheal tubes. Okay, so remember this. Now, what is this tube? This is called ring Alder Edwin tube or RAE tube. The name is because it is preformed, and you know it can be of two types, North Pole and South Pole tube, depending upon which site they are operating. Okay, so RAE tubes, remember this. Now this is nothing but this photograph has been asked, and this is a fluid warmer, which is also important to us not to misunderstand this. And what is this? This is dynamic compression stockings. The idea is to prevent DVT in patients who are bedridden or who are lying post-surgery in ICU with immobilization. Along with that, it is highly recommended you can use enoxaparin of 0.4 or 0.6 depending on the patient weight. If it is prophylactic, OD, or if it is therapeutic, go for BD dosages. Okay. So dynamic compression stockings, remember this. Now, what is this one? This is again a discovery which has been multiple times asked for your exams, called bispectral index. Bispectral index is nothing but it is a unitless value which you get, which ranges from 0 to 100. 0 is patient deep anesthetized, 100 is awake. So you want the value something between 40, less than 40, to say good general anesthesia. Something between 40 to 60 is okay, but 40 is a target. Okay, remember this value. Now, what is this one? This is called Trendelenberg position. Trendelenberg position has been asked. They asked you to find out Trendelenberg position where the head is down. When the head is up, it's called reverse Trendelenberg position. Now there is another position where the patient will be lying down on side with hands flexed and the one limb extended. This is known as a recovery position. And recovery position, patient should be breathing spontaneously, and he should be hemodynamically stable. Okay, so remember Trendelenberg position, reverse Trendelenberg position, and the recovery position. All this has been asked for exams. A very easy, repeatedly asked question. What is this method known as? This is called EC technique. This is the this is the limb E. And this is the C. So EC technique is used in mask holding. And this is originally put forward by WHO. And you all know that mask holding becomes difficult when you don't have teeth, a dental patient. When you have large beard, it becomes difficult. Okay, so mask holding is important, and never you should mask ventilate a patient who has got a high risk of aspiration. Remember that. We know fluids can be classified into natural and artificial. Again, they can be classified into crystalloids and colloids. Although has been in use for a long time, now we don't use much of colloids, and we primarily depend upon colloids, crystalloids. So crystalloids can again be classified into RL, normal slide, DNS, isolate P, and the latest one, plasma light. Of it, the plasma light is considered to be the most isotonic for nowadays for use, while RL is the fluid for intraoperative volume resuscitation or replacement therapy. So perioperative fluid therapy is usually done on RL, while normal saline is basically to correct the sodium level and also to bring up the blood pressure in some cases. Remember, a dextrose containing fluid, let it be DNS or 5% dextrose, not to be given to a patient with a CNS insult. It can precipitate a cerebral edema. Okay, so this is one thing you need to remember. Okay, so this has also been asked. Now, this is called a vortex approach. Vortex approach is nothing but it is a representation that you have to stay in the green side using various techniques, like let it use mass ventilation. Let us use using mass ventilation, an ET tube, or an LMA. Use all these three devices and try to oxygenate the patient somehow. This is called the three instrument use vortex approach, so that you keep on to the green side, which is oxygenating. By any means, if you cannot do that, the patient will slip into the central tunnel where it becomes deep blue. Blue is considered to be cyanosis. If you fall deep down, then the option is only surgical. As you can see, you'll have to go with surgical techniques. Nicholas Crane is the one who actually suggested this, and this is called a vortex approach, which has also been asked. Now, have you any idea regarding which are these molecules? These molecules are rocuronium, and this is sugammadex. So when they come in 1:1 ratio to form a complex which is eliminated through urine. Okay, so when you get this picture, remember that this is a 1:1 ratio of rocuronium and subex. Okay, so remember this. Now, another easy and sure short question which you have is this one. What is this? This is a capnogram. As all of you know, capnogram is an important one which you get for exam, and this is very easy also, isn't it? So when in the initial time you have the phase 1 where air from the dead space comes, so which doesn't have much of carbon dioxide. Then you get the phase 2 where you have alveolar air coming out. Then you have the plateau phase, and then finally you have a small phase 4 in certain individuals, and then fall back to that's phase 0, which is the beginning of the inspiration, isn't it? This is a normal capnogram, and this is alpha and beta angles, the two angles. Now this point corresponds, the uppermost point corresponds to the EtCO2, end-tidal carbon dioxide, peak EtCO2. EtCO2. Okay, this is a normal graph. So we should know why 1, 2, and 3 are produced, and why there can be a 4th stage only in certain individuals, especially pregnancy and those patients with poor lung compliance, poor compliance as such, not only lung, even obesity people have this, they need an extra effort to pull the excess carbon dioxide out, producing a tailing. Okay. Now the question they ask is, which is this type? This is called the curare cleft, isn't it? Curare cleft seen on the EtCO2. Curare cleft is because of the muscle relaxant need to be supplied. It is getting empty and patient is taking spontaneous breaths. Okay, please remember, along with this, you have multiple capnograms like this, which you know, this is COPD or asthma, as in case of what do you call this? This is called the shark fin appearance. Shark fin appearance of the capnogram. Also remember, after intubation, if you get a capnogram like this, sudden disappearance, it is tube into the esophagus. And whenever you have a sudden disappearance of capnogram, remember there is an embolism, or there is a cardiac arrest, or there is a tube getting disconnected, or there is secretion blocking it. So sudden disconnection is that. So like that, you have multiple situations. If there is a gradual rise, every breath it keep on rising, then you are talking with about a malignant hyperthermia or a neuroleptic malignant syndrome where there is an increased metabolic rate. So all these things about capnogram also you should remember, because you are very high possibility to get one question on capnogram also. Okay. So with this short span of time, I try to cover majority of the pictorial questions that you have got in your exams, and you have a tendency to come. Any doubts further, you can get back to me. Okay, or you can mail me at GMC, Dr. Karthik, Gmail. Okay, so any doubts on this, any questions on this, we'll be happily answering, and happy learning, and all the best for your exams. Okay, thank you.